Welcome to the American Shoulder and Elbow Surgeons podcast. I'm your co-host, Brian Waterman, a sports and shoulder surgeon at Wake Forest University in association with Atrium Health. I'm fortunate to have Peter Chalmers, a shoulder and elbow surgeon at the University of Utah in Salt Lake City, as my co-host today. Peter, how are you doing?
Oh, I'm doing great. I'm so excited to be here.
Awesome. So before we get started, I should mention that the views expressed in this podcast do not necessarily reflect the views of the American Shoulder Elbow Surgeons, the University of Utah, Wake Forest University, or the institutions of any of our guests. Okay, it gives us great honor to welcome a couple of personal mentors and thought leaders, not only within our subspecialty community, but also the orthopedic field at large. These individuals truly belong on the Mount Rushmore of shoulder surgery. First on our list is none other than Anthony Romeo from Chicago, Illinois. Tony, welcome to the podcast.
Thank you very much for inviting me. It's a real honor to be here.
Yeah, it's a pleasure to have you. Next, we'd like to bring in Dr. Mark Schickendantz from the Cleveland Clinic. Mark, welcome and thanks for taking the time to be with us today.
No, thanks, guys. I really look forward to this. Great topic, and we're excited about it.
Well, without further ado, let's dive in. Our charge today is to take a deeper look at a topic that is literally near and dear to our hearts, that of the pectoralis major rupture, as well as lat dorsi and teres ruptures. Maybe, Tony, we can start with you. Let's start with, for many of our listeners, they may only know a world where pec tendons were repaired with endosteal buttons. But I remember a day when transosseous tunnels, suture anchors, bone bridges made this somewhat of a delicate procedure. If you could, would you mind walking us through your initial approach to these injuries and how they've evolved in terms of treatment?
Certainly. So, in general terms, they come into two types of tears. And the one we see the most is where the inferior part of the tendon or the clavicular extension of the tendon pulls off inferiorly. And what that does is that it's usually done when they're bench pressing or trying to lift a very heavy weight. The other type is when the tendons completely turn off, and it includes both parts of the pectoralis major tendon. Now, you can tear at the muscle tendon junction, and many people will say, oh, this looks like a bad one because it looks like it's the muscle that's pulled off. Usually that's that inferior part of the pec that's torn off, and it is such a short tendon. It is mostly muscle, but you can usually find a tendinous structure that you can repair. And so these tear and move medially, obviously. And so the treatment is to do an anterior approach. And the easiest approach is a deltopectoral approach, but most people kind of stayed away from that, thinking that's more of a reconstructive procedure. They do some type of variation of more of a straight up and down axillary approach, but then deviate off the top of the front part of the axilla. So I think either way works fine. Honestly, a lot of times a deltopectoral approach, just keeping it a little bit lower, especially when it's a rupture after weightlifting, ends up being a fairly cosmetic repair. And then we go down and we have to do two things. You find the tendon insertion on the lateral part of the bicipital groove, of course, and you need to isolate the biceps because you want to move that out of the way to protect it when you repair the pec down to where it belongs on the ridge of the lateral intertubercular groove. And once you've seen where the tendon's thrown, there's always a few little fibers there. You want to see from top to bottom so you know exactly what the overall length is. And then you go medial, and sometimes it can be way far medially. And the trick is to find the inferior part of it, and you have to free it up from the fascia. You have to free it up from the skin. And oftentimes, especially if it's been there for a few weeks or even longer, you have to free it off the rib cage. It will go medially and scar into place, and you have to reach down and feel the ribs and lift it up. And remembering where the innervation comes in place on the top part of that, you can usually get a pretty nice mobilization of that tissue. And then, that's basically the exposure that we have. And then there's a variety of different ways that we can actually repair that. I'll just mention the open approach used to be to take a drill. Sometimes people used a curved drill and drill a hole in the medial part of that ridge. And then on the lateral part of that ridge, So you basically went around that, and you could pass your sutures through and then tie everything lateral to the ridge on the lateral side of the humerus. And that was a pretty good technique, because you could pull on the tendon and sew it laterally in a nice secure position. But I'll stop at that. But that's the really kind of the way that we did that from the very beginning.
Well, that's just a great overview. Maybe I could follow up with you, and then we'll get to Dr. Schickendantz. You talked a little bit. You sew it to the bone. I think you've done some important work in understanding when you say sew, what do you mean? So tell us a little bit about suture arrangements. Often these tears, there's a lot more muscle and not so much tendon.
Yeah.
What is your method? What is the method you use for getting fixation on the tendon side with your sutures?
Yeah, so pretty much everybody has used some form of a crack-out stitch. And again, when it's just the inferior part of the pec tendon, we'll do just usually 2 sutures. You can put a third if there's enough room for that. And so that gives you 4 limbs of non-absorbable suture. In the early days, believe it or not, we would use Ethibond, but now everybody uses some type of suture that's a super strong suture and much harder to break. And you do a crack-out stitch on the inferior part of it and a crack-out stitch on the superior part of it. And you have these 4 limbs. And then honestly, the technique we would do is we drill 3 holes, typically a centimeter or centimeter and a half apart. You'd put the top suture through the top hole, the bottom suture through the bottom hole, and then the 2 in the middle through the middle hole. And then you bring them around and match them to their remaining suture and tie that into position. There are some publications out there where there's been a full tendon tear, and people have been able to put multiple non-absorbable super strong sutures in place and get pull-out strengths above 600 Newton meters, which is way beyond muscle tendon. But that usually requires a very complex and interlacing suture technique that I don't think has ever been shown to be any better than the ones where you get a nice solid attachment to the upper and lower part, and then the sutures come through the middle. You can add another stitch in the middle to help reinforce that if you like. And because of this kind of configuration, that's why it became really nice when we developed a technique where you could drill a hole in one side of the bone, and you could use a metal button and pass the sutures around that. And then a technique that is referred to as a tension slide technique. We'd put the sutures with the suture holding stitch on the top part of the tendon, and then another one on the bottom part of the tendon from these buttons. And you pull on the suture that's free, and that would drag the tendon all the way down into your area of the bone that you prepared. And I should mention, I think everybody knows, you typically will take a rasp or a burr and debride the bone where you're reattaching it just very gently, call a paprika sign, establish a bony healing response. And again, you'd pull on the 2 free sutures, and that would reduce it down to place. And you could then tie your knots and get a very secure repair. And you can even go a step further, instead of using suture, and use tapes. And that's where people were able to show biomechanically you get the strength around 600 Newton meters or higher, which is far beyond what tendon muscle strength is required to actually hold it in place. So you can make these very robust if you want to.
Mark Schickendantz, how does your technique typically compare to that? Are there differences, similarities?
I love the tension slide technique. I love using the available buttons for that. I agree with the crack out stitch on one limb, and then the second limb just coming straight through without any grasping. That will allow you then to do a very simple tension slide technique. It works well for me. I've been doing this a long time. Back in the day, as Tony pointed out, we used to do this with curved drills and drill holes, and kind of a similar way we used to do open rotator cuff repairs way back when. But the tension slide technique with a suture button, endo button type fixation has worked very well for me, and that's what I prefer to do.
Peter, I just want to add one thing to that, and that is that there were a variety of different buttons that were available on the market in 2010, but they were had a flat end to it. So if you were going to put them inside of a bone only on one side, you had to drill at an angle so that it would hit the opposite cortex and it would spin on you. And that sometimes was kind of hard to do. And it turns out that I was actually doing a latissimus tendon repair on a athlete that had won a Cy Young Award. And I broke a bunch of sutures trying to get this fixed. And as you know, the latissimus tendon attaches on the medial intertubercular ridge. And so it's a very similar type of repair or fixation, but I just didn't have the tools at that time to make that work very well. We ended up kind of doing a MacGyver type thing where we took some old anchors and passed some non-absorbable suture through it, and it worked. And I wasn't going to use a curved drill because it's in a spot where you have some pretty significant nerves, and I wanted to just use one side. So there was a possibility to then design a button where it had like a slight curve to the side of it. And so when you put it in, it would spin a little bit. There's lots of different ones now, but actually when that was first designed, it was designed for a latissimus tendon repair, but we knew there were so few of them. It was called the PEC button kit. So that's where it originated for using that and using the tension slide technique that actually was developed in conjunction with biceps tendon surgery initially, the same idea. And that kind of put all those different techniques together that made it much easier to get that tendon to drag down to the prepared bone.
Yeah, it's been really fun to watch this evolve over time, and it is a slick technique. It wasn't always so. I think the other thing that has been interesting to evaluate is the timing of presentation of these tendon injuries. Certainly, when we look at this academically, there's often this discussion about acute, subacute, chronic pec tendon ruptures, but the divisions between them are somewhat unclear. Dr. Schickendantz, does this matter? Does this really change how you counsel patients or ultimately what you're doing in the operating room?
You know, it does for me, and you know, I don't have a lot of science to back it, but I use 6 weeks as my acute phase, so that anywhere from 0 to 6 weeks I would consider them acute. Anything from 6 to 12 would be subacute. Anything beyond 12 weeks I would consider chronic in nature. And just like any other major muscle rupture or tendon rupture, you know, my experience has been the longer you wait, the more difficult it is, you know, to mobilize that tissue and get it back down anatomically where you want it to go. And you know, I think my outcomes probably aren't quite as robust as they would be in a repair that's done at 4 months than a repair that's done at 6 weeks. Now, I don't have any personal science, you know, back that up, but that's just kind of been my gestalt on it. Now, you know, that being said, you know, I think we've all run into situations where, you know, you'll have a chronic rupture, you know, greater than 3 months that you cannot reduce to the bone. And then you need to start thinking about grafting and those sorts of things. And, you know, I think that the outcomes from an allografted pectoralis major tendon repair is not likely to be as successful as a primary repair if you can get it done. So, you know, when patients come to see me or I hear about these injuries, you know, I encourage them to come in early. I think personally that the outcomes for me are better. It's certainly easier for me technically to get it done, and I think my outcomes are better if I can get it done in a timely manner.
Can I follow up with you about that? I think that's a super interesting point. And what I want to follow up with is the question of, I think what you mentioned is true in terms of chronicity. One piece of chronicity is atrophy. You know, when that muscle is disconnected, it starts atrophying. And we know this from, you know, a lot of careful research in the rotator cuff. Here's my question for you. Is there a tipping point at which atrophy is irreversible? And if so, what is that tipping point? Is it 3 months after which you would say there's going to be some atrophy you will never be able to get back? Or is that patient dependent? Like, what do you, because I've had patients ask me that, and I don't know what the answer to that question is. What do you think?
You know, that is a fascinating question, Peter. And, you know, I really don't know. We don't have a grading scale for pectoralis atrophy, you know, as we do for rotator cuff. But I would imagine it would be somewhat along similar lines. And you know, I would say once you start getting to the equivalent of a grade 3, atrophy in the pectoralis muscle belly, perhaps that would reflect, a challenge for repairability, a challenge for, reconstitution of muscle mass following repair, much like it would be in rotator cuff surgery. That's a great question, and I think something that needs to be studied. Tony, what do you think?
There's no doubt at some point there's enough atrophy that it's really difficult for the athlete to get this back to make it look symmetrical. I think one thing I wanted to go back to on these chronic tears, there's a couple of points just for the surgeons in the audience here. And that is one, when you get control of the tendon edge or the kind of thick tissue that you have and you pull it over, I can't emphasize how much the importance is of mobilizing that muscle unit. And I know it sounds unusual, but you can go over the top of the muscle all the way over to the sternum. You can go down underneath to the ribs, and you can go up to the top wherever it is where the nerve is at, so that you know where that's at, to mobilize that structure. And that's really important when you go on these chronically, because it gets stuck to the skin, it gets stuck to the ribs, and just trying to pull on it is not going to work. So that's one thing. The other thing is that if you've done everything you can, and then you use this technique that Dr. Schickendantz talked about using the buttons and the tension slide, if you can get the native tendon to the humeral bone, even if the arm is by the patient's side, it will stretch out on you. It's a lot like the distal biceps tendon. It's a scary experience. It makes you nervous. You know, when you try to do a distal biceps and you've got the arm flexed up 60, 70 degrees, and you're like, he's never going to get his extension back. The pec is the same way. If you can get the native tendon over to the humeral bone, its insertion site, even if it's close to their side, it will stretch out. So on those chronic ones, you just keep those two in mind, because I do believe, as Dr. Schickendantz said, once you have to use a tendon, it's very hard to cosmetically match the other side. And that's the point I wanted to make about it. When you atrophy the muscle. If you can get that lower part of the tendon in the right spot, and I've seen where people have accidentally put it just like 2-3 centimeters too high, and it's whether the muscles atrophy or not, it doesn't look right. They have a gap down there. So what's really important, again, at the very beginning, identify that lower portion of your tendon and make sure you repair it there, because even if the muscle atrophies, when they're not, when their arms are at their side with most activities, there'll be a very minimal cosmetic defect, which is what they worry about. And so I would just keep that in mind.
Yeah, that's great conversation. And that's been my experience as well. Certainly seeing those thrive when you feel like they're repaired under significant tension, and being able to dial in that tension using your technique. Both of you have led the charge on that. Let's take it a step further then. You know, you've talked about how probably forgiving the primary repair is. What about the dreaded myotendinous junction disruption or the intramuscular tear pattern? And then you have to use a graft. And so the big determination is when and how to tension that. Tony, can you offer us your pearls of wisdom on that?
Yeah, it's you start moving from the science to the art. It is tricky, and it depends if you do it early. I had a gentleman who was going for his maximum at 465 on his bench, and he missed it, and he felt an explosion in his chest. And when I went in there, he had pec muscles as chunks of meat that, from the force of the pull and the snap, they were just detached. It was like literally pieces of meat that I had to just remove. They were non-viable. And so when you're all done, you're looking at a gap of tissue and a big guy and this distance. Now, he was cute. I was able to repair it by incorporating muscle to muscle, but I did put a graft over the top. Now, what graft? There's so many different grafts today. You could consider a number of different ways. I kind of always liked the utility of the Achilles tendon graft. So for me, the Achilles tendon graft, as it fans out, gave you the option. You can oftentimes wrap that even around the bottom part of it and to incorporate it in. And then you can incorporate, side to side repair, muscle to muscle, and then the tendinous, a graft over the top of that. So almost like when you're trying to, repair muscle to muscle, that doesn't have much strength, but then you reinforce it with that Achilles graft over the top, and then bring that tissue, the collagen tissue, over and incorporate that into the final repair into the tendon. So that's the way I've done it. And it does work, but it's hard to get that to fill out exactly right. And I have seen a number of patients referred to me where something like that was done and they don't have any pain, but you can tell that when it all healed, it was a greater length than normal. And so they have a gap there and they're very disappointed about it. And on rare occasions, we have to go in and actually take out part of the reconstructive tissue and shorten it to get it back to its normal appearance. And, that's orthopedic plastic surgery for the most part. But some people are very, very conscientious about those things. So I think that the trick is to have a good understanding of what your overall length is. Try to get the muscle back to the muscle as close as possible and hold it there, oftentimes with absorbable sutures, and then reinforce it with the graft that can either be just directly over the top or it can be almost like a sandwich type graft that holds it all in place.
Yeah, Tony, that's a great way to do that. I've done that as well. In terms of tensioning, I tend to err on the short side, so I put it in with them shorter. A little bit more adducted than long, because as you pointed out, they don't tolerate long very well. Again, it's the art, not the science. I'm not sure if it's the right answer, but I tend to want to do that and keep them a little short.
I agree with you, Mark. That's what I try to do the same thing.
And maybe, Mark, I could ask you this same question. What is your preferred graft? Are you using the Achilles? And then maybe as we get to that, how do you approach sternal versus clavicular head? The mention of the sandwich makes me really think about the way this tendon is. It's really two tendons from two muscles that are kind of overlapping one another. How do you think about reconstructing that as you approach these injuries? And is that different for isolated sternal versus combined head injuries?
Well, as you pointed out, it's a complex, it's a complex anatomy there. The pec tendon is about 5 centimeters top to bottom, and it sort of flips on itself and folds on itself. And I personally don't really focus on trying to isolate the two heads and reconstruct the two heads. Maybe I'm missing something and need to be doing that. I'm just, quite honestly, in these big chronic tears where you're considering maybe a graft, I'm just happy to be able to get a graft around it and get it to bone, at all, let alone trying to, split the two heads. So I personally, I don't think it makes a difference, to try to reconstruct the sternal head, try to reconstruct the clavicular head, as separate entities. I like the Achilles. I like the way it wraps. I use that for distal biceps as well. I think it works very well. The other alternative is to go to one of these durable patches. I've used the Arthroflex patch for that as well. Sort of a wrap technique. It's not as big as the Achilles, so you can't do it for a big gap. But I found that to have some utility as well as a graft option.
So Peter, if I get in there, it's a weightlifter, and it's just the sternal head, the part coming underneath the clavicular head. I actually do try to go medially and separate out the two. The sternal head portion that extends proximally, goes into what we call the falciform ligament. So you end up working above and below the clavicular head insertion point. And, there are oftentimes, part of the tendon's left there, so you can't really see exactly where they're separated, but you get a sense of the two muscles. And if I'm just repairing the sternal portion, I can do that. But if at any point I feel the clavicular part of it's been compromised or it's completely involved, I agree with Mark. We just try to grab the whole thing at once and keep it as, sort of isometric between the structures as possible. But a lot of these guys are weightlifters, and it's just that inferior part. And so I will at least make the effort to try to preserve the clavicular section. I sometimes will also, as we bring it back over and we're fixing it, I will pass the sutures that we're fixing the sternal head, but I'll go ahead and pass the sutures up to the clavicular head too, so we reinforce that repair laterally and bringing both of those together.
Now, we've talked about the humeral side. Have you guys seen sternal or clavicular sided ruptures of the pectoralis? And if
I have
so,
a great story here.
Those?
A
Please.
great story. I get a call from a plastic surgeon. Dr. Romeo, I have a patient who wants to remain anonymous, and he's torn his pec muscle off of his sternum, and I tried to repair and it didn't work. Would you be willing to help me on this? I'm sure we can do him here in the hospital. Oh, no, he doesn't want to come to the hospital. So we go to the plastic surgeon's office. This gentleman was a police officer. He decided to become a female and went through the transition process, including the breast implants, for about a decade. And then he decided, you know what, I like it better being a man. His implants were put subpectoral. And so those were taken out. And he was a sergeant, a very well-known sergeant in the Chicago Police Department. And they did not know of this past history of his. And he was bench pressing and he ripped his pec off the sternum. So the plastic surgeon went in there and just tried to sew it down. It didn't work. So what I have done in this one case is I just passed the, you have to make a slightly bigger incision. It's not as cosmetic as what it started. And you need to pass your sutures through the ribs and the sternum. You cannot do this soft tissue alone. You have to pass it. And you can either do that with very sharp needles, which work pretty well, or you can do it with a small drill and pass it through. But you have to capture it in the bone, and then you sew almost like a tendon holding stitch onto that medial muscle, and it's thick enough and gristly enough that it will hold the stitch. And no activities for 6 weeks, and they heal up and they do okay.
That's fantastic.
That's quite a story.
Yeah.
Can you match that for us, or maybe do you have any stories on the clavicular side?
You know what? I don't. I just tip my hat to Tony. That is a great case and a great story. That is great.
I tried to write it up, but I couldn't get consent.
I got it. Let me throw something out here to you. We wrote an article a couple years back on pectoralis injuries in baseball, and we had over 7 seasons, 138 injuries. We had 5 ruptures, and the ruptures occurred, not on the field. They were weight training ruptures, and most of them were, 5 of them, and they went on to repair to be repaired. And I wondered, Tony, your thoughts on and everybody returned to sport. Are there special considerations in an overhead athlete with a pectoralis major rupture that we are trying to repair? Are there special considerations for how we do it? Is there something we need to be careful about, or how we rehab these things to get them back to throwing and hitting?
Honestly, I don't know the answer scientifically. I would hypothesize that it's similar to the latissimus tendon, and that is, since it's outside of the joint, you repair the tendon early, you repair it well and anatomically, and it will stretch back out or adapt to what it needs to do, because the glenohumeral joint itself is not affected by it. So I think the important principle would be, don't wait on that one, fix it, and they should rehab. But just like with lats, it's remarkable, and some of the activities they do, it may take up to a year before they feel super comfortable doing all the things they want to do.
Great, thank you.
Yeah, Mark, I've wondered often the same thing. What are the considerations? What's the allowance that we get with these various different injury patterns? Building off that, I really wanted to dive in the rehab aspect quickly. For a straightforward repair, I think we have a pretty standardized protocol for the first 3 months. But as we start to initiate closed chain exercises, and discussion inevitably migrates back to when you can resume bench press. So for you, Mark, is this a time-based criteria? Do you use isokinetic data to inform this? Is it strictly based on patient demands? Talk me through when you allow them to start pressing plates again.
Well, I think it's all those things. I think time helps us a little bit. For me, all other things considered equal, it's a minimum of 4 months, so 16 weeks to do even the lightest, activation against resistance, for the pecs, even the lightest dumbbell work. Obviously, if there are complications, you might need to slow that down. I certainly wouldn't speed it up past that. I'm not sure that measured isokinetic, values can guide us too much on that. I think I depend a lot on patient feedback, on therapist feedback. How are things going? And I think it's just like anything else we do. It's a slow progression of increasing, weight, increasing frequency, increasing intensity slowly, building up load, and kind of monitoring the clinical progress. And I tell my competitive weightlifters, listen, it's probably going to be a full year before you're back, even close to where you were in terms of lifting. And so I think for me, the return to lifting program takes all of 6 months to get better, and to get back up to maximum weight at the highest level of in the weightlifting world. I think for your recreational lifters, I think it's a similar amount of time, but probably not quite as long. So I would say it's a 6-month process, for your elite athletes, and I think you can get guys that are more recreational, back, after, so 16 weeks before they lift, about 4 months to go through that. So another 16 weeks of rehab, and slowly progressing back to their weight.
Yeah, I would agree with Mark, and I would just say that, and not just weightlifting, but obviously as part of the sport, but in football in particular, we do see these, the defensive lineman reaching out, trying to stop a running back going full speed, and he's going to just have enough strength to essentially try to stop that guy. They're just too powerful, and the pec rep pulls off. You can get it in offensive linemen when they get their arms out wide and they're trying to slow somebody down. And if it needs to be repaired, I tell the guys, you're not going to be back to lifting to where you think you're lifting like you used to for about a year. Now, you're going to be able to go back working out at pretty steady pace. I like to see them in the office, somewhere like Mark said, usually around 4 months. If it's just the lower part, they might get it as early as 3 months, but I want them to be comfortable to do push-ups and feel that without significant discomfort. And I tell them to do it first on your knees, so it's less resistance. And then when you can do standard push-ups and you can do a set of 12 to 15 and you don't feel it bothering you, can progress with your weight training. Now, some of these guys are so big, they can start doing the bar and gradually work their way up before they do a full push-up. But if they can't do a set of 12 to 15 push-ups, I do not turn the green light on, so you can do whatever you want. And then usually that, as Mark said, is somewhere around 4.5 months, they start progressing. By 6 months, they're doing well, but they don't have any explosion. They can feel like, yeah, I can push it, but they don't feel that sense of really being able to explode with their pressing activity. And that's important in a sport like football. So that really does slow them down. They can get back to all their other activities at that point. But then somewhere around 9 to 12 months is where they finally get to where they're comfortable with it. They feel good about it, and they're getting their strength back to where they want it to be. And if they're going for their maximum, I tell them that's a number you're never going to see again unless you want to have another injury.
That's a great point, Tony. Great point about the explosiveness. Particularly in your power athletes, like your NFL players or in college players. Great point.
Yeah, they'll do pretty well at 6 months, but they kind of talk to you about how, it just doesn't feel right. And you can imagine one of those running backs running full speed. They're not going to stick their arm out there. They're going to let that guy go by or hit him in the knees or something. But it's they're not ready for that kind of effort yet.
Yeah, that's great.
So let's pivot to lat teres injuries. These are pretty rare, but they really can be seen in elite throwers as well as in some other niche mechanisms. Mark Schickendantz, you've had a lot of experience with this. Tell us about your experiences with this injury pattern and how you've approached these thus far.
Well, we published a small case series of these in 2009. I think there were 10 of them. Everybody came back. We didn't have any real long-term follow-up. We didn't have any good performance data. And, Tony and I talked, and clearly there needed to be, further investigation on these things. We had more of a descriptive study. Hey, just pay attention. These things are out there, so look for them, and you'll find them. And that was kind of the purpose of what we did. And then, Tony and others started to look deeper into it, and did in fact find out that the non-operative treatment of latissimus injuries in our elite throwing athletes, particularly our MLB players, while they were able to return to sport, most of them were able to return to sport, but there were some important pitching metrics that were not quite back to where they were before they were injured, and then it got everybody thinking, well, maybe there's a subgroup of these that need to be repaired. And in typical Tony fashion, there's a question, he's going to come up with an answer for it. And he and Brandon Erickson and others, and you, Peter, and you, Brian, have looked at this and came up with a grading system that made some sense with regards to severity, and it gave us some guidelines to kind of parse out who is going to get better without surgery, but who might benefit from a surgical procedure, and it's led, I think, now to a more sophisticated approach that it's not a one size fits all. I still say, and I think Tony would agree, the vast majority of latissimus injuries can in fact be treated non-operatively, but there is a subset of them, and we can talk about that, that do better with surgical intervention. And with that, I'll hand it over to Tony, because he's really been the one who's championed this, and he's got a very thoughtful and methodical approach to it. So Tony, why don't you chime in?
Yeah, as they say, when you're trying to think about what to do for these things and you have to try some science, sometimes your hand gets forced, and necessity becomes the mother of invention. And so one of the players we had was a very high level guy, and he tore it off completely. You could just see it drop down. So it was a 3 or a 4. And he was very, very conscientious about his body, like many pitchers are. And he went and saw Dr. Andrews, and Dr. Andrews said, "Oh yeah, you got to have that fixed." And he goes, "Okay, when do you want to do it?" And he goes, "Well, I don't do it. You got to go back to Chicago, have Romeo do it." Of course, he never called me and asked me how many of these I'd fixed. But I had talked about some papers where I did latissimus transfers for chronic massive rotator cuff tears, and I think he got mixed up a little bit. But actually, this was the first professional baseball player that I actually performed a direct repair on. I had a wrestler that I did it once on, but that was it. And that was when we ran into the fact that we didn't have quite the right fixation that we wanted. But that just sent me into a tizzy, like, we got to learn more about this stuff. And so Mark's paper was great. It told me that even if we treated him non-operatively, there was a reasonable chance he'd get back. He just may not be at the same level. And all athletes know that that is a potential risk of a chronic injury. And so we had some sort of a baseline to look at that. And then what ended up happening is a number of players who had basically come to the point where I'm going to give up baseball, or I'm going to have this fixed because I just can't throw again. It came to me. And when we did our first paper of 11 athletes, the average time to surgery was over 1 year from the date of the injury. And one, I was happy that I was able to repair them. And two, they did remarkably well. If nothing else, they got rid of this pain that they would get deep down in their armpit that some of them could overcome to some degree, but it always aggravated them because the lat is such a powerful decelerator of the arm. So at the end of the throw, they would feel this. And because of that, they wouldn't throw as hard as they possibly could because they didn't want to get that achiness in their shoulder. And so we went from there to then, so let's start fixing more of these. And as Mark said, I think if it's completely off, the evidence is reasonable that we have a better chance, a higher percentage of getting our professional pitchers back to the same level or a similar level using advanced analytics as our endpoint than as it we're able to do before the injury. If it's not completely off, and particularly we have a 2A and a 2B. So 2A that it's off, but it's less than 50%. I think we should draw that as our line and say you should treat everything that or less non-operatively, because most of those patients, and I think it's somewhat similar to hamstrings, you have the 3 tendons up on your ischium. If one pulls off, most of them do pretty well. And if it starts getting more than that, you may get in trouble with your power athletes. But here's the same thing. If some of it's still attached, I think it scars back into place and it scars to the adjacent teres major, and they do okay. But the one where it's more than 50% off, we just have to watch those. Some of them do okay and some of them don't. And I think it's worthwhile to still pursue non-operative care, because as we found out, this is not a surgery that has zero chance of complications. There can be complications like with any surgery. We've been fortunate enough to minimize that, but it can happen. So I think if it's completely off, my recommendation is have it fixed. Not every player does that, and some of them have learned to do okay without having it fixed, especially what I would say a more senior level player in their 30s. They're like, Doc, I don't want to go through a whole year and a half of rehab. I just want to, play just for another year or so, and they'll do their best to make that happen. And so I think most of those 3s and 4s where they're completely off should be fixed. But the 1s and 2As, they should be treated non-operatively. Keep in mind the recovery time. Sometimes they can put on a 10-day, disabled list. These things can take 90 days or longer to get better in some of our pitchers. Some of them will do remarkably well. And the 2B is the one we just have to watch and see how they respond. And if they go through a gradual and appropriate recovery phase, we can let them continue. But, if they go 60, 90 days and they go back to throw, they start feeling it again, the chances are not good that they're ever going to get back to the same level. And so they're either going to have to accept a lower level of performance or they're going to have it fixed.
Well, you certainly indicated a couple areas where you can kind of step in it in this procedure. Let's talk about them, right? Access to the footprint, recreating the native vector of pull, navigating that challenging neurovascular anatomy. Tony, we can stick with you. What are your tips on executing this? Can you give us a top 3 for how you address this and how your perspectives have evolved on this surgically?
Yeah. So if it's barely off, there is a group of surgeons that will approach this from an anterior approach, and they'll go medial to the biceps tendon and they'll grab the tendon. But by the time you do the surgery, between the time of the injury and the time of the surgery, it may have moved on you, and you may not be able to grab it, and you may then have to make a second incision. So with these more significant grade 3 and grade 4 tears, I've just learned to go from a posterior approach. It's a hockey stick approach over the posterior axilla. And why I like that approach, especially in chronic cases or bigger tears, is that the lower part of the incision, I'm in what's relatively normal structure. I'm at the healthy part of the lat and teres. And then I can follow it proximally, and I can get on the medial side of the lat and protect my radial nerve, and the lateral side of my teres major and protect my axillary nerve. And I can put some blunt retractors there. And now I've got a very safe neurovascular zone. I've got both of those muscles and tendons in front of me, and I can figure out exactly what the tear pattern is and get that back down to the footprint. I mean, it's not, the other landmark is that, as you know, it attaches just below the circumflex vessel. So when you go down to the humerus, you want to make sure you're below that level. But these are big time neurovascular structures. If you have a problem with one of those, they're not going to be able to do their sport. So you have to really, I don't think you do this blindly. I think you know where they are and protect them. And then you just repair it like you would the pec tendon, which is a much safer zone with the pec side than this one. And this is really important when you're going to do chronic tears, where that area actually fills back in with scar tissue, and it gets hard to tell what's normal tendon and what's scar tissue just by looking at it. You literally have to feel it with your fingers, and you can feel where the end of the real tendon's at, and you have to excise the other tissue. And if you're not comfortable with your view and your protection of the neurovascular structures, you're going to shortchange yourself and be able to get these repaired.
Well, that's great. Certainly a lot of words of wisdom on how to do the repair. Complicated surgery, as you mentioned, a lot that can go wrong. I wanted to ask you, Mark Schickendantz, about one aspect of the non-op treatment which we didn't get to, which is there a role for PRP in this setting? And if so, what is that role? Certainly, I've seen players treated that way. I still don't feel like I have a great understanding for who gets it. Tell us about your protocol there.
Well, for the lesser grade injuries, that at least based on MRI criteria, if we think this is going to be a non-operative case, again, which most of them are, we count on the musculoskeletal ultrasound to help us characterize the extent of the injury and the absence or presence of a hematoma. So if we have, let's say, a grade 1 or 2A that's relatively low grade, we'll take a look with the ultrasound, and if we find a hematoma or an area of flocculation, we tend to aspirate that. And what we have found is that if we get that out of there, get that blood, that irritating blood out of there, it helps them to then get back into their rehab and makes them a lot more comfortable. The PRP right now, we don't do it every case. We don't have a lot of science behind that, obviously, and we don't know for sure if it's beneficial or not. We haven't thought we don't have a prospective study going forward with any sort of randomization or parameters. It's sort of a conversation we have with the athlete, and offer that to them as an option. Most of them take it as an option because they want to do everything they can to try to get back sooner rather than later. I know one thing we don't do is any steroid injections, anything along those lines. We're trying to get healing. We don't care about calming down that the inflammation with any sort of a steroid injection. So we don't have a lot of science behind the PRP. We are using it, and hopefully we'll be able to take a look at it and have some better understanding as to whether or not we're doing the right thing or not. But we do like using the ultrasound. We do like aspirating hematomas, and we have found that that's been a help in letting these guys get back a little quicker.
Yeah, just to piggyback on that, I haven't seen any real indication for using it for augmentation of surgical repair. So I would agree with Mark. Early on, there's oftentimes a lot of fluid, or a lot of blood, especially when the teres major is partially involved. And taking that out can make the athlete feel much better. And then somewhere around 2 to 4 weeks, if they still have some lingering discomfort and you obtain a new MRI, there may be just a little fluid there, but they're sore. It's, I would say, investigational. It may help with the inflammatory healing response and guiding the healing response better. Much like some individuals have found with regards to treating partial hamstring injuries in the NFL, some athletes will respond to this and that soreness and achiness goes away pretty well. So they get 1 or 2 separated by a week to 10 days, and that may help accelerate their level of comfort and ability to start their rehab program a little bit sooner. The other place I've used it is in those who have a chronic injury and overall do well, but they keep having episodes of soreness or achiness. And we have at times shut people down for 4 to 6 weeks, do 2 or 3 PRP injections because their only other option would be then to have surgery. And again, I have found, and it's anecdotal, but again, just as another story, because that's what a lot of we do. I had one that was sent to me. We did this to him. He felt better, and he was traded because his numbers went down a little bit. So he got traded to another team, and that team went on to win the World Series. And so he got a World Series ring because he stuck with it that year instead of having surgical repair. So for him, it was a benefit, and the PRP definitely helped him, and he felt better, although he wasn't able to return back to the exact same level of performance, but he made it through. So he was 32 years old. He just wanted to keep playing, and at least subjectively felt like it made it a significant improvement. As Mark said, we don't want to take the risk of putting cortisone in there, so I'm not sure what else we can do.
what I take from that is PRP equals World Series. Okay, I'll
Yeah,
write that
well,
down.
if you're lucky, if you get traded to the right team or you're on the right team, it can happen.
It's
But the
almost
key
like,
is, as everything we do, the most important thing we do is keep them on the field, no matter what. And sometimes we have to operate, but the whole goal is get them back on the field because that's where it all counts.
Well, your anecdotal experience as well as your data-driven approach to both of these conditions has been huge for me personally, and I'm confident that our followers will be well served by all the words of wisdom that have been featured here. Just on a personal note, both Peter and I want to thank you both for your mentorship and your commitment to excellence. Really a great podcast. Thank you for being on this evening.
Mark and I think, I don't know if you know this, but Mark and I went to the same medical school, St. Louis U, and we were at the same residency, Cleveland. He was my chief resident. He used to beat me up in the gym. We did our rounds in the gym, which was awesome at the end of the day. But Mark and I think would both agree. All we ask of you guys is just pay it forward. Keep doing what you're doing. Do these podcasts. Learn. You guys are two of the brightest people in our profession. Keep teaching the next generation. And it's all worth it to us, and I'm sure it'll be worth it to you guys too.
yeah, thanks very much, guys. I really appreciate you having us on. You guys did a fabulous job. This is a great program, and we're very, very, very happy to be part of it. So thank you very much.
Well, certainly from our perspective, it's amazing to have you both as guests. And for these particular things, there's not a lot of literature, and there was a lot of wisdom in the last 45 minutes to go through the challenges of addressing these difficult cases and avoiding the things that can go wrong. For me personally and for Brian, I really appreciate both of your time and all the help you've provided to us and to our field in general. This is about all the time we have for this podcast. For all of our shoulder ambulances out there, don't forget to subscribe, and we will see you next time.